Hello and welcome to another episode of PA Notes. Now, in today's episode, I'm going to cover breathlessness. Or in other terms, shortness of breath, or SOB. As usual, I'm going to try to give you like an acronym to help you deal with this kind of OSCE scenario. So I've got something quite simple here. Let's zoom out a little bit. So the first thing I try today is to ascertain the situation. So S for situation. The second thing I like to ask is the onset of it. And I also like to know about the duration of it and any progression of the condition and the timing of the condition. Okay, there's no particular name to the way to say this. It's just SODPT. Hopefully this will help you in at least having a structure for your OSCE. So let's start with the S. So S stands for situation. Situation. It's quite important to understand from the patient what has been going on. So you can ask the patient what happened, how did they develop the shortness of breath. So you can say, just the situation. How did you notice it? Okay, or you just ask them simply, what has been going on? Obviously, open question. Tell me more about your symptoms. Okay, so it's important to start a very simple way. Second thing you want to know, focus in is the onset. So onset, O for onset, which is when did it started, or I always try to say when did you first notice it. Okay, very important. And is it quite important to understand, especially for shortness of breath, was it sudden? Or was it a gradual onset? This will kind of give you like an idea of when to be worried or not worried. It's also important to understand how long have the symptoms been there. So D for duration. Okay, so it's been 1 week, 2 weeks plus. So you can understand if this happened the last couple of hours. You can start to think some differentials. We're going to cover some differentials later down the video. It's also important to understand the progression. Now, you want to know if the symptoms are getting better or they are getting worse. Okay, so just say getting better or worse or the same. Sometimes they just remain the same. Okay, and last but not the least, you have timing. Now, this is also quite important to understand the timing of what is happening. So, is it continuous? Okay, that is they're short of breath all the time. Is it on and off? On or off? So triggered by certain things, just like exercise or anything like that. Okay, so you want to, in the timing, let's add another point. Change the color, so we can say an extra arrow. So we can say, okay, your symptoms, do they occur normally or with exercise? And you can say normal. So you can ask about the normal exercise tolerance. So you ask normal exercise tolerance. Okay, because most of the time shortness of breath will occur with exercise, but sometimes a patient will present with shortness of breath without exercise, and you need to have some differentials for that. Okay, so you can compare their normal exercise tolerance versus the new exercise tolerance, so versus current tolerance. Okay, so it's quite important to know that. So you can ask more information from the patient in regards to their shortness of breath. So you can say, is it worse at night? Worse when they go to bed or when lay down? Down. Okay. And does this happen every season? So you can say seasonal. Obviously, being winter being the common time for patients to be short of breath. Okay. Then you can ask some extra questions, which is the kind of like general questions. So we can ask extra questions. There's so extra. Okay, so we can say, okay, any fever, any night sweats, any leg swelling, any weight loss. Okay, and what you're trying to do is to understand what is going on in a general type of manner. Okay, then you can ask some extra questions which are more, so we just say cardio resp questions. This could be chest pain. You want to ask them about palpitation. You want to ask them about cough, and obviously explore that in more details. I'm going to do a separate video for cough, just to make sure we cover a bit more detail about cough specifically. And obviously ask them if they're producing any phlegm or sputum. Okay, and again, leg swelling. Okay, so these are kind of like the associated symptoms. If you want to keep it quite structured, you can say associated symptoms. At this point, you've got an idea of what may be going on, hopefully. Okay, so let's talk a little bit about the differentials that may be going on when you're thinking about shortness of breath. You want to think about the cardiac causes. So let's just say cardiac causes for shortness of breath. So the first thing you want to think, obviously, is your big one, the MI or the heart attack. Okay, so this is quite important when you're taking the history. That's why you need to ascertain if the patient's symptoms are acute or chronic. So acute being an MI is always acute. Okay, and most of the time the patient will present with shortness of breath. Okay, and if this happened during the night, it will definitely wake them up. Okay, sweatiness, being sweaty, clammy. Okay, obviously the patient being not themselves, and sometimes they will also be nauseous, even vomiting. Obviously, if it's the heart that's involved, you have a central crushing pain. Let's try this. Chest pain. So it's like a central crushing chest pain. Okay, and oftentimes this tend to happen to the elderly, to the patients that have diabetes. So you can say they can have comorbidities. With this, okay, or cardiovascular risk factors. Okay, so your first big differential is to rule out MI. Another cardiac causes you should be aware of is obviously heart failure. This is generally patients that are a bit more elderly, and they would just have underlying cardiovascular risk, and they would just call you maybe in a GP practice and yeah, shortness of breath, and this is kind of new for them. Okay, so shortness of breath being the presentation, obviously. The main thing will be what we call orthopnea, which is shortness of breath when lying down. Okay, and you have shortness of breath when lying down, or paroxysmal nocturnal dyspnea. These are big words, so let's just say dyspnea at night. That's a mouthful to say. I don't even know how I said that. Okay, another thing, again, you're looking for keywords, buzzwords when you're in an OSCE scenario. The first thing you need to look for, or if a patient tells you they've noticed a pink frothy sputum. Pink frothy sputum. Okay, this is a big one when you are taking a history. Okay, but this only occurs when it's like an acute phase of it. Okay, and that's what basically means that they have left ventricular failure. Obviously, when you're asking about leg swelling, you have peripheral edema, or they just put edema. Okay, and again, you have the cardiovascular risk factors. Okay, so this is the main things you want to rule out when you're taking a shortness of breath history. Okay, so let's go to the next differential. So another cause of shortness of breath is obviously your respiratory causes, which is basically what most people will go for anyway. Okay, so one of the most common causes of shortness of breath, especially acute, is your classic respiratory infection. Okay, infection. Okay, so that will obviously be an acute presentation of shortness of breath. Okay, you will have fever, not all the time, but sometimes they may have fever. They will also have some cough, and they will present with some sputum, which is generally, I would say, green, yellow sputum. Let's move this to the side a little bit. Okay, that's the main things if you want to think about your classic respiratory infection. Obviously, you need to also think about pneumonia. Okay, and this is particularly true with elderly. And if it's pneumonia, you want to think about the CURB 65 score, which C stands for confusion, U for urea. Obviously, you can do that in a GP practice. And R for respiratory rate. Obviously, this is more than 30, you have to get worried. B stands for blood pressure. So if the blood pressure is less than 90, you should be obviously worried, or equal to 90. Okay, and 65 is just an extra point. It's like a scoring system. We go from 1, so just say score 1, 2, 5. Now this may vary from trust to trust, okay, but hopefully it shouldn't vary too much. So you can say response. So if the patient score from 0 to 1 is classified as low risk, so they don't need hospital admission theoretically, okay? So you can consider home treatment. If they score 2, now there's an increased chance that they will need to admitted to the hospital, especially if they're elderly with a lot of comorbidities, okay? And if they score between 3 to 5, you need to be much more sure that they need admission. So just say certain admission. Okay, hopefully you don't get that too often, but if during the OSCE they ask you about the CORP 65, you just make sure you know what they stand for, and you take it from there. So just another thing, obviously, if you're in the hospital and they give you like some values, if the urea is more than 7 millimole per liter, yeah, they score 1 for that. Okay, so that should help you have an idea. The second thing you want to be aware of when taking a history of shortness of breath is the big one, isn't it? The asthma. Okay, obviously it's like a shortness of breath plus on and off wheezing. Okay, so it changes. Most patients will say worse at night, and other will say worse with mainly all of them will say worse with exercise, and you know, some of them may be allergic to pets. So yeah, so you need to check, you know, pets or plus any allergens. So this is kind of the easy one, I would say. If you get that in the nationals, well, or whatever assessment you got, you're in good luck. So next to asthma, you have COPD. Obviously, this is a chronic condition, chronic shortness of breath. Okay, and they may go on and develop, obviously, the symptoms of lower upper respiratory infections, which need to be managed accordingly, and blah blah blah. Okay, one thing you need to always be aware that they have a smoking history, so always advise patients to cut down on the smoking if they want to increase the quality of their life. Okay, and depending if it's emphysema or chronic bronchitis, they will have production of sputum. And obviously you need to, in a GP practice or in a secondary care setting, you will probably need to manage that accordingly. And so these patients can be quite tricky to manage because they may be under a specialist, and you know, it's quite difficult to manage chronic COPD patient. But it's something as a differential to mention during your assessment. Another thing to be worried about, or you should know about, is pneumothorax. Okay, so this is sudden, absolutely sudden onset of shortness of breath. The patient is tall. Okay, and obviously you have the differential, you know, tall and thin, aka Marfan. But that's not necessary that all tall and thin people will have this kind of shortness of breath, but it's just something to be aware of. It's like a risk factor. We have pleuritic chest pain. Basically, chest pain worse by breathing in and out. That's it. And they may also have some respiratory risk comorbidities of history. So be wary of them. Obviously, you have to be worried for tension pneumothorax, which is a whole different type of scenario. But yeah, be careful from the history. Taking a good history will help you to differentiate that. Just a couple of more differentials. So another one to be aware of, just put it right here, is PE, or pulmonary embolism. Okay, so this, obviously the risk factors are the common one: long flight, recent surgery, being female, pregnant, obese. Generally, these are the main risk factors for PE. And just like that is like a sudden onset. Okay, this generally evolves from a DVT. So should we just like put DVT becomes PE, so you kind of like have an idea. Yeah, the main thing that will give it up is hemoptysis, hemoptysis, or coughing up of blood, really. Yeah, they need to go to the hospital if it's that bad. And yeah, so that's the main things. You need to be aware of pulmonary embolism. There's more to it, but in a OSCE scenario, you want to have an idea if this is a PE situation. The buzzword is hemoptysis, and maybe okay, we have the pleuritic chest pain also. Just write this better. Pleuritic chest pain. Okay, the screen is quite busy, but I hope you guys can understand the differentials. Another thing you should be aware is pulmonary fibrosis. Okay, this is generally progressive. It's like a progressive long-term shortness of breath, which is generally managed by obviously a respiratory team, because it's something you wouldn't manage as a PA in any point really. Okay, but they may call you or present to the clinic with shortness of breath. Another thing they will present with is probably some dry cough. And that is another thing you kind of like will be aware of it. Okay, some extra differentials to be worried about or to be aware of about when taking a shortness of breath history. One of them being anemia. Okay, and generally it's a female population that will present with shortness of breath, or actually will present with tiredness all the time, or tired all the time, and you want to take a good history from there and ascertain if it's anemia. So be aware of that. Another type of patient that you may find in your clinical practice, probably not during an examination for OSCE, but could be anxiety. So they may present with shortness of breath or hyperventilation. So yeah, that's another interesting differentials to have. Another cardiac cause that I kind of like, I wouldn't say missed out, but may present with shortness of breath is aortic stenosis. Aortic stenosis, which could be either a incident finding during your examination, or you start the whole process for finding out about left ventricular failure or heart failure, and you find that the patient has aortic stenosis. Other lung causes could be TB, which is, depending on the population. You have a patient that presents with shortness of breath, cough, hemoptysis. So have that in the back of your mind. And as usual, after you've done all that, you want to finish up with the final pieces, isn't it? Pieces of your consultation. So you want to make sure you do a check for the past medical history, or any surgical history actually. Make sure you check for the drug history, any allergies, medications, obviously. So allergy, never forget that in an OSCE scenario. You say current meds. Obviously, also asking about any over-the-counter medication they've taken. Any family history, very important. You check for the family history. Depending on the comorbidity it is. Social history. This may be quite important when you speak to patients that may have asthma or COPD. Okay, and never forget to ICE the patients, which is idea, concern, and expectation, and you can finish up your OSCE scenario, OSCE station, and hopefully you've done well enough to pass the station, and you can move to the next station. I hope you guys enjoyed this video, and I'll see you in the next video. Don't forget to like and subscribe to this channel, and if you think this is good, you can share it with your friends and colleagues. Great. Have a nice day, everybody. Goodbye.